deficiency anemia. You got a patient of thalassemia minor whose TIBC is high, that patient requires iron therapy to improve the hemoglobin. If you got a patient of tuberculosis or recurrent urinary tract infection or ovarian cancer who's got anemia, serum iron is low, but if TIBC is high, iron therapy will correct that anemia. The other test is ferritin. Now, very often this test is not asked, and that's very, very unfortunate, because low ferritin is once again diagnostic of iron deficiency. There is no other disease which produces low ferritin, unlike low iron, which can happen in other conditions. So hemoglobin low, ferritin low, transferrin saturation low. Please do not misunderstand that iron and ferritin are identical. They are not identical. They are different. They are as different as ovarian cyst and ovarian cancer differ. So normal hemoglobin in a man is anywhere from 13.5 to 17.5. In a woman is 12 to 15.5. So anything less than 12 in a woman is anemia, and anything less than 13.5 in a man is anemia. So if I have a hemoglobin of 13, I am anemic. My wife has got a hemoglobin of 11.5, she is anemic. Ferritin, less than 40 in a male, less than 20 in a female, is iron deficiency. And transferrin saturation normally is 12 to 20 to 50%, irrespective of the sex. Why should you do ferritin test if you have done serum iron TIBC? And the reason is that ferritin tells you about the stores. As you know, that there are stores in the body for iron which help us in supplying the iron regularly to the marrow whenever there is supply which is deficient. Maybe due to dietary reason, maybe due to GI tract, maybe due to excessive loss, and so on. So this is ferritin, this is hemoglobin, this is something normal. By the time you come over here, there is no ferritin in the body and the hemoglobin production goes down. So this is overt anemia. And in between, there are conditions where ferritin is low, but hemoglobin may be good. We'll come back to this a little later on. So if you look at the serum ferritin, it is very low in iron deficiency, iron depletion. These are normal levels, and these are positive levels or overload levels. Another cartoon telling you the same thing. That this is frank over iron deficiency, where the stores are totally depleted. The marrow iron is absent, the serum iron is low, the transferrin saturation is low, and the hemoglobin goes down with red cells being hypochromic microcytic. This is what undergraduate is taught. But you have to understand this, because you got to pick up the iron deficiency at this level when RBC morphology is normal, the hemoglobin is okay, the transferrin saturation is okay, the serum iron is okay, but the marrow iron is depleted. Now you can't do bone marrow examination for iron deficiency anemia. So you look at the storage iron, and that you do by ferritin assay. There's one more term, soluble transferrin receptor assay. Less often available, but today you've got standalone labs all over the country, and you can have an access to this even if you're sitting in Timbuktu. Why is this important? It's extremely important because this is the test to differentiate between iron deficiency versus anemia of chronic disease. This is very important for the hospitalized patient. You've got a patient admitted in the hospital. That patient could have iron deficiency due to colon CA, and that patient may also have, because of malignancy, anemia of chronic disease. The STFR will tell you whether this is due to iron deficiency, where the STFR will be high, or whether this is due to anemia of cancer, where the STFR will be low. So when you can't make out in a case of cancer, in a case of TB, in a case of arthritis, whether there is iron deficiency or not, do STFR and it will be high. So that is what tells you over here. Soluble transferrin receptor is increased in iron deficiency. It is not increased in anemia of chronic disease. Well, I can go on and on and on. What this tells you is that in iron deficiency, there are certain more sophisticated tests as well. Zinc protoporphyrin, hepcidin, inflammatory markers, ferritin-bound iron. These are not available to you and me in the clinics, so we can skip this. Now let's change gear and move forward to iron metabolism. Normally in our body, a man has 4 to 5 grams of hemoglobin. Well, a woman has 3.5 to 4 grams of hemoglobin. Now, this hemoglobin basically is in hemoglobin, 2/3 of it, but there is a significant amount of it in the myoglobin and the enzymes. And this is extremely important. You could have a hemoglobin of 14 or 15 grams, but you may feel fatigued because your muscles are not working. You have various other symptoms which I showed you in the beginning of my talk because the enzymes are not working. You may be a vegetarian or you may be a non-vegetarian. In India, 90% of us, even if we are non-vegetarian, are basically vegetarian because the non-vegetarian food is eaten only occasionally. This could be due to monetary grounds. Non-vegetarian food is expensive. This could be due to religious grounds because you have been brought up to be told that your religion does not permit non-vegetarian food to be taken, like Jains and so many others. Or this could be that you are non-vegetarian, but you just take it only once in a while. So predominantly we are vegetarians, so our source of iron is from the plants. The difference is important because the iron present in the animal source, like in the meat or in the fish or in the liver or in the chicken, there is no mucosal block. It can walk it from the intestine into the liver. It can just go through. While if you take vegetarian food or the plant-based iron product, there is a mucosal block. Very little iron is absorbed, just about 10% in a normal healthy person. So you take 10 milligram, 1 milligram is absorbed. You will have to take 100 milligram to absorb 10 milligram and so on. And that is because of this particular hormone, I can call it hepcidin. Hep is for liver, sidin is something which kills. About 20 years ago, when a microbiologist picked up this 25 amino acid structure in the urine and called it hepcidin because he traced its source to the liver, production from the liver, and he showed that this is an antimicrobial substance. The microbes also require iron for flourishing inside our body. So body has this protective system. When you are infected, hepcidin is produced in more quantity so that iron is not available to the microbes to flourish. Now this hepcidin is a master hormone. What it does is it acts at the GI tract and blocks the absorption of iron from the GI tract. It also acts at the level of reticular endothelial system and blocks the release of iron from there. So overall, no iron is available to the bone marrow. So all the conditions where hepcidin production is high, iron is not going to the bone marrow. Etiology of iron deficiency. So far we talked about anemia and I gave you signs and symptoms of anemia. Then we talked about iron deficiency and we talked about how to diagnose iron deficiency anemia. The third part is very important and your job is not complete unless you find out why does a man or a woman or a child become iron deficient. So the cause of iron deficiency has to be searched in each person. The cause may be as simple as poverty. If a child is malnourished, if his calorie intake is poor, if he is not getting a nutritious diet, first thing that happens is iron deficiency. It could be due to ankylostomiasis. You are a farmer, you've been working in the farms barefoot, ankylostomiasis incidence is 90%. And they suck away all the blood and with that all the iron. If you are in the urban population, you are economically quite forward, H. pylori is a common infestation of the stomach in India and many other countries. This chronic H. pylori infection of the stomach leads to atrophic gastritis, decrease in the production of gastric acid. And as you know that the dietary iron is in the ferric form, and to be absorbed, it has to be converted or reduced to the ferrous form. And once there is atrophic gastritis, no acidity, you can't absorb iron. Tea contains tannic acid. Go for a party, you have a sumptuous lunch or dinner, followed by a cup of tea. And when you take a cup of tea within 30 minutes of your lunch and dinner, the tannic acid content of the tea blocks the iron absorption. Same thing happens with coffee. There is a very, very common disease, and which is not understood, is celiac disease. Many people, except the gastroenterologists, feel it's a rarity. It is not a rarity. Celiac disease is gluten enteropathy, and the staple diet of North Indian is wheat-based. So it is based on substances which contain gluten. And when you got this malabsorption, this leads to significant iron deficiency. In celiac disease, because it's an inflammatory disease, there is also anemia of chronic disease, what's called anemia of infection, anemia of inflammation. And the treatment is you have to make your diet gluten-free. Today, fortunately, in India, gluten-free diet is available left and right. Well, in today's world, especially the women, especially the young girls, they all want to look slim. They don't want to be overweight, and they often go for extreme dieting. And your lunch may be just like this. And that leads to severe iron deficiency. So when you've lost 20, 30, 40 kg of weight in a period of 2 months, 3 months, sure, you will become iron deficient. And what is this? This is treatment of obesity. This is bariatric surgery. In bariatric surgery, you are compromising the gastric function. Now, once you compromise the gastric function, your iron absorption is impaired for the rest of your life. Even if you got bariatric surgery done 8 years ago, unless you take supplements, you will become iron deficient. Iron is bad for the body. So far, we were talking about the iron is good for the body because it is required for the formation of blood. But excess of iron kills you. It makes you diabetic. It damages your liver. It damages your heart. You can get arrhythmia and cardiac failure. So nature has made iron a very precious metal and has seen to it that iron absorption, besides this mucosal block through hepcidin, is also blocked by various other contents in the diet. We just talked about tannic acid, phosphate, oxalate, pancreatic secretion itself, taking of antacids, calcium, and antibiotics. They all can inhibit calcium iron absorption. And of course, there are other substances which enhance the iron absorption, like vitamin C. Many times the student answers, take an orange and it will help your dietary iron absorption. But in a poor country like India, where is orange available to 90% of the population? So this is sort of a bird's eye view of etiology of iron deficiency. In pregnancy, you need more iron. Children who are growing need more iron. You may lose iron in the form of bleeding from various sites, especially GI tract. There may be poor intake, socioeconomic factors in the vegetarian. There may be poor absorption. And this is a master blaster, sort of an expansion of what I showed you just now. Inadequate intake, reduced absorption, hookworm infestation, bleeding, increased body need, chronic blood loss, inflammatory diseases, and so on, and the role of hepcidin. I had a rare patient of a hepatic adenoma secreting hepcidin coming with recurrent iron deficiency. Now we come to something which is more closer to you. Iron deficiency anemia in pregnancy. In India, it is unthinkable, and it is unthinkable even in the Western world for 70–80% of the women to go through a pregnancy without needing iron support and not developing iron deficiency. This statement, I cannot teach this to the gynecologists and obstetricians. Every pregnant woman needs iron supplement, including those who have thalassemia minor. That's a hard fact to be remembered. I like to quote this case study, which is a real case seen by my own eyes. 26-year-old woman, pregnancy, 35th week, was brought to the emergency gasping. She was severely pale. She was in cardiac failure. She was hypotensive. Her blood was collected for the workup and cross-matching to push in some blood. Before the blood could arrive, she was no more. An investigation showed that hemoglobin was 1.9. This is the type of iron deficiency that we see in India. And this woman reached when she could not be salvaged. Look at the classical picture of iron deficiency. MCV, so low, you hardly see in clinical practice. WBC normal, platelet normal, retic okay, ESR bit high because of anemia, serum ferritin gone, serum iron gone, TIBC high, and transferrin saturation. This is classical iron deficiency, but this report came after the patient was dead. So iron is important. Whose responsibility is it that this woman died? You can keep pointing finger at various people. Antepartum and postpartum anemia, and iron deficiency is the leader. And when the iron deficiency occurs in pregnancy, it is problematic both for the mother and the baby. It affects the health of both. So perinatal iron deficiency has tremendous implications for the mother and infant. And if you look at the prevalence of iron deficiency, it keeps rising with each trimester. First trimester, second trimester, third trimester. This is iron deficiency anemia accounting for majority of that. Other factor being folic acid, etc., which we are not discussing in this talk. Antepartum anemia impacts over 1/3 of the women globally and 3/4 of the pregnant women in India, leading to major maternal and perinatal morbidity, peripartum transfusion. Tell me, will you like to take a unit of blood transfusion? However best your blood bank may be, as you know, no blood is zero risk. You can get HIV, you can get hepatitis B, hepatitis C, malaria, venereal diseases, some odd viral infections, or you may get allergic reaction, or you may die of anaphylaxis. Now, all this is avoidable if you took care of iron deficiency during antepartum. Maternal death, I showed you the case. Maternal infection, preterm birth, and neurodevelopment disorders affecting the offspring. If you want to give birth to Einstein, you have to be non-iron deficient. Postpartum anemia impacts 80% of women in India and 50% of women in Europe and US. And it leads to peripartum depression. Have you ever realized this? Fatigue, impaired cognition, and altered maternal-infant bonding. If a woman with this symptom goes to a physician, he would not think of that this is iron deficiency causing these symptoms. So maternal iron deficiency affects postpartum emotions and cognition. This is publication. The contribution of iron deficiency and the risk of peripartum transfusion, I cannot emphasize it more. And look at this. Peripartum blood transfusion anemic woman, 1 unit is required in half of the pregnant woman, 2 units in 1/3, 3 units, 4 units, 5 units, even 6, and more than 6 units may be required by some women. And the timing of transfusion in the postpartum period is just at the time of delivery in majority, within 1 month and within 2 months, most of them. This just tells you the index of non-treated antepartum iron deficiency anemia. Child is preterm, low birth weight, small for gestation, decreased auditory recognition memory, and cognitive and behavior abnormality. Brain development is totally dependent upon the iron which is available to the fetus and infant. Can you imagine maternal iron deficiency leading to risk of schizophrenia in the offspring? Hepcidin levels also are important for the transfer of iron from mother to the baby in the utero. So far, we were talking about iron deficiency anemia. Is iron deficiency with normal hemoglobin important? It is extremely important. This is called non-anemic iron deficiency. You are a woman, your hemoglobin is 14. Will you order for serum iron study? Will you order for ferritin? No, but you must. If you got symptom of fatigue, depression, suicidal tendencies, and so on, you must. So iron deficiency without anemia, even to think about it and to order the test and to treat it is a clinical challenge. It's a relatively new concept, not very new, but relatively new concept. And many of you may think of today for the first time that if a man has got 15 grams of hemoglobin, you should do his ferritin. So hemoglobin can be normal, but the patient is symptomatic. The 2 symptoms which are often not given importance to is fatigue and restless leg syndrome. It just affects your sleep. And fatigue, of course, affects your performance whole day. So fatigue as the chief complaint of iron deficiency without anemia. Iron deficiency without anemia is a potential cause of fatigue. Meta-analysis. Fatigue due to iron deficiency without anemia can be cured by a single dose of IV iron therapy, which we'll discuss on next Friday. Effect of intravenous iron on fatigue and general health of non-anemic blood donor having iron deficiency without anemia, and so on. Restless leg syndrome. RLS or restless leg syndrome affects 1/3 of the patient with iron deficiency. Mind you, iron deficiency, not iron deficiency anemia. Patients get brief, rapid involuntary movements. They also get semi-rhythmic movements during sleep, which disturbs their sleep. You just can't get sleep and then whole day you are tired and fatigued. This is recording of periodic leg movements of sleep using what is called polysomnography. What is the mechanism? Mechanism is deficiency of iron-dependent enzymes in substantia nigra of the brain. This is a cut section of the midbrain. So there's substantial paucity of iron over there, and this has been shown by doing MRI of the brain in 70% of patients. Decreased serum ferritin and transferrin saturation correlate with restless leg syndrome. And once again, one dose of IV iron, these symptoms are gone. So iron deficiency without anemia can do many more things. It can make you angry, as is this study in young Japanese women. It can impair your cognitive function in young women, as in this study. Another study, cognitive function. It can affect your mood, cognition, and functional ability of elderly people. So if a grandfather is losing temper, he may be iron deficient. If he is not able to comprehend, he may be iron deficient. Iron deficiency in menstruating adult women, much more than anemia. So remember, if your woman has got little heavy periods, she may be able to maintain hemoglobin, but not iron stores. And then the enzymes don't work, then the muscles don't work, then the heart does not work. So there are tremendous benefits of correcting iron deficiency without anemia. The last part coming to is chronic disease. We look at this case study. A woman has hemoglobin of 8.5. So commonest cause is iron deficiency, right? MCV, MCH are low. Commonest cause is iron deficiency, right? However, she's got recurrent urinary tract infection. Well, 1/3 of the women have it. So this is incidental. No, this is not incidental. This is leading to anemia of systemic disease. What recurrent urinary tract infection or tuberculosis or any other chronic infection or inflammation or malignancy do is to liberate gamma interferon and interleukin 6. All these suppress the production of erythropoietin. All these suppress iron going to the marrow by increased hepcidin. This increased hepcidin leads to trapping of iron in the reticular endothelial system. So there is enough iron in your body, but at the wrong place. It doesn't go to the bone marrow. So you become iron deficient. Well, forget chronic diseases. You get one viral infection and you do your hemoglobin after 1 week, it has dropped by 1-2 grams because excess of hepcidin interfering with iron going to the marrow. Now, this is concept of functional iron deficiency. Enough iron in the body, but no iron in the bone marrow is functional iron deficiency. This is a state of hyperhepcidinemia. Tuberculosis, recurrent infection, chronic inflammation, anemia of cancer, anemia of chemotherapy are all examples of functional iron deficiency. Have you heard of this term? IRIDA, iron refractory iron deficiency anemia. What's this? Iron deficiency anemia not responding to iron. So iron refractory iron deficiency anemia. We have a substance in the body called TMPRSS6, TMPRSS6. TMPRSS6 leads to excess of hepcidin in your body. And that leads to blockade of iron absorption. This is genetic disorder. Mind you, you almost never think of it because everything looks like iron deficiency. But if your patient has got iron deficiency and she is not responding to iron, do TMPRSS. And you will find that patient may be having mutated TMPRSS leading to malabsorption of oral iron due to excess of hepcidin. And these patients respond to injectable iron. And if you don't have an access to TMPRSS mutation studies, All these patients who don't respond to oral iron, but their data looks like iron deficiency, low serum iron, low transferrin saturation, low ferritin, give them iron. So I conclude my talk by saying knowledge is important. Though many things that I spoke today may be known to many of you, for them it was a rapid revision, for others it's a good amount of knowledge. Well, thank you so much for giving this opportunity to me. You're most welcome to ask questions. If you put your questions in the chat box, maybe we will be discussing them now.
So thank you very much, sir. And it was very great feast today evening. We started very simple from the etiology of the anemia and the diagnosis of anemia. We have seen some simple tests. We have gone to as high as IRIDA, which was pretty new for many of us, including me. Also, we discuss in between the case studies, which is very pertinent, and I could never even thought of somebody having hemoglobin of 1.9 gram per deciliter. So we discussed many things, sir. I am very happy to tell you, sir, we have 1,550 active login doctors listening to you across the country. So there are few questions which has been put forth, but before that question, sir, I just want to understand from you. In India, where we is a resource limiting country, so in the resource limited situation, what basic investigations are required for diagnosis of anemia? Do you recommend TIBC and serum ferritin and serum iron studies in each and every patient, sir?
So I'm a teacher, so I start with history. Take the history. Symptoms are only of anemia and nothing else, and that nothing else is very important. Examine the patient, and there should be signs of iron deficiency and nothing else. So you got pallor, you got koilonychia, you got bile tongue, but no lymph nodes, no liver, no spleen, no icterus, no purpura. So no is very important. And the chest is fine, your abdomen is fine, everything else is fine. Once you do that, you do what is called CBC, the complete blood counts. So unless you've taken a good history and good examination, don't even go to CBC. And CBC to a hematologist like ECG to the cardiologist. In that CBC, the WBC is normal, the platelet is normal. The hemoglobin is low. Look at the MCV and MCH, both are low. Look at the peripheral smear and is hypochromic microcity. Once you have done this, then top on the list is iron deficiency anemia. Competition is with thalassemia minor because, you know, it's endemic in India. In this part of the country where I'm sitting, Mumbai, you've got huge Gujarati population, you've got Mohammedans, you've got Marwaris, you go to the north, west, you've got Punjabis, Sindhis, you go to northeast, you've got Assamese, Bengalis. Where is thalassemia not there? It's there all over. And it is hypochromic microcytic anemia. In the CBC, there is a way to differentiate iron deficiency from thalassemia minor. The RBC count is high in thalassemia minor, but it is low and as low as the hemoglobin. If the hemoglobin is 1.9, RBC count will be very, very low, maybe 1 million. But in thalassemia, if the hemoglobin is 9, the RBC count may be 6 million, 7 million. Then there's a test which I didn't discuss, RDW, red cell distribution width. If you look at your electronic cell counter data, the RDW comes as a printout, so you don't have to do anything. You just look at it. It is always high in iron deficiency. It is invariably normal in thalassemia minor. The third commonest cause of low MCV, low MCH is anemia of systemic disease, which I have discussed so much in my talk itself. After having looked at CBC and thought of, is it like iron deficiency? Is it like thalassemia? Is it like anemia of chronic disease? You do serum iron. That is low. You do TIBC, again emphasizing it is high, and you do transfer. You look at the transferrin saturation is a calculation. You look at that, it is low. Now, when these figures are not very convincing, because they can be topsy-turvy due to so many other conditions, do the ferritin. Ferritin is an expensive test. And as you ask about resource poor country, history is free, examination is free, peripheral smear is free, CBC costs 10 rupees. Serum iron TIBC doesn't cost more than 100 rupees or 200 rupees. So within about 300, 400, 500 rupees, you got the diagnosis for majority. And then if you need, you do the ferritin. And ferritin is sine qua non because low ferritin doesn't occur in any other condition. As high TIBC does not occur in any other condition. To diagnose iron deficiency without anemia, which I emphasized so much today, you require ferritin. You require TIBC. So I would stop there because usually we don't go beyond this to diagnose iron deficiency. Rest everything that I spoke is not required in clinics. And then the rest of the tests are to find out the cause of iron deficiency, which is, again, a shrewd clinician can make out clinically. But one thing not to miss, if, of course, I'm talking basically to obstetricians and gynecologists, but if you've got an elderly population, is occult malignancy in the GI tract. So if somebody is more than 40 years, 50 years, non-menstruating woman or a man having iron deficiency anemia, not to investigate the gut is a sin. It's criminal because you could detect a major pathology in the gut, which is curable today and non-curable tomorrow. So that amounts to killing somebody, isn't it? So it is unethical not to think of that. So stool local blood, upper GI scopy, lower GI scopy, scan of the abdomen. So when you think there should not be iron deficiency and there is iron deficiency, you have to sort of turn the whole GI tract up and down. But otherwise, children, growing children, menstruating woman, pregnant woman, you can be comfortable that there is obvious cause for anemia looking at you. You don't have to search for it.
So thank you very much, sir. Very from the basics to very advanced, you have explained how we can rule out and differentially diagnose and come to the proper conclusion to anemia. Only thing is that we need to spend more time with the patients for history taking and doing the examinations and signs and symptoms. That's very critical and important. So there are a few questions from the chat box. Some of the questions may not relevant to this topic. So this today, or we may take into the next session. So there's one question which comes pretty 2-3 times. There is a link between vitamin B deficiency, vitamin B12 deficiency and anemia. You do touch upon the building blocks, and we restrict ourselves to the iron deficiency anemia. But how's the role of vitamin? We all understand there's a role of vitamin B12. So is it? So it says that how frequently vitamin B12 needs to be evaluated, or it should be supplemented directly without examining the vitamin B12. So that's one question. So second question pertaining to this is that in chronic conditions like IBS and all, whether there's a chance of vitamin B12 deficiency.
Okay. So yeah, like iron is a most important building block. B12 and folic acid are equally important building block. Only thing is the type of anemia you get in B12 and folic acid deficiency is different. It is macrocytic anemia. So MCV is high. The red cells look large under the microscope. Plus, because B12 and folic acid are required for DNA synthesis. So they are required not only for the production of RBC, they are required for the production of RBC, WBC, and platelet. So you get pancytopenia. Your hemoglobin is 6 grams, your WBC is 3,000, your platelet count is 80,000. That can never happen in iron deficiency. So mild pancytopenia, macrocytosis, large red cells under the microscope, plus the neutrophils, as you know, they get hypersegmented, more than 5, 6, 7 nodes. This suggests you that this may be megaloblastic anemia, B12 or folic acid. Clinically, I didn't show you the picture, but there can be melanosis of the dorsum of the hand. Look at the knuckles and they'll be darkened. Indians are dark-skinned people. Despite that, even in the darkest of the dark person, you'll find that the knuckles have become darker. I've got patients where the wife has brought the husband saying, just look what has happened to his hands. They've become dark like coal. And they look at the front has also become absolutely like coal. So that tells you that there may be megaloblastic anemia, the commonest cause of megaloblastic anemia. Now, B12 and folic acid deficiency, you can do the B12 and folic acid levels, but they are less widely available and less reliable in the clinical practice. And the reason for that is very often a general practitioner gives multivitamin pill. Now, when you give multivitamin pill, and next day you send the person for B12 and folic acid assay, that B12 and folic acid are getting absorbed from the gut. They are in the blood. Your levels come sky high. And first thing you say, okay, there's no B12 folic acid deficiency. That's the commonest cause of wrong diagnosis. Or he gives an injection of multivitamin, where the B12 level and the folic acid level come sky high. So those are the problems of B12 folic acid. The last thing is B12 and folic acid are water-soluble vitamins. If I give you tons of it, it does no harm to you because it just walks out in the urine. Unlike iron, if you're not iron deficient and keep giving you iron, you get complications. You get iron-induced damage to the organs. So that's a criminal act. While B12 folic acid, even if you don't have deficiency and I give you, I do no harm to you. And as is undergraduate teaching, iron, B12, folic acid go hand in hand. Underprivileged country, poor population, economically background, nutrition is bad, or even in the rich people, dieting, GI problem, etc., you become iron, B12, and folic acid deficient. B12, intrinsic factor comes from the stomach. Absorption is from the ileum. Folic acid is absorbed from the jejunum. So you talked about irritable bowel syndrome, celiac disease, there may be other Crohn's disease, there may be ulcerative colitis, there may be any gut problem, including bariatric surgery. So all these lead to GI problem. You can iron, B12, and folic acid deficient. All my iron deficient patients get B12 and folic acid supplements because I'm doing no harm to them. Even if I'm giving them when they are not deficient, I'm doing no harm to them. It just goes out in the urine and they are very cheap. So you are neither economically doing a harm nor bodily doing any harm. Plus you are treating people without bothering too much to do investigations which may be false normal.
False positive.
If you are very keen to do, you can do homocysteine level, which is invariably raised in B12 folic acid deficiency and not affected by a general practitioner giving B12 folic acid. Okay.
Sir, let's move to the last one or two questions, or maybe last question. There's a lot of buzz around the hepcidin blockage and all these things, and we do discuss about this hepcidin blockage. But how in clinical practice we should identify, or we feel that now instead of oral iron, one should move to the injectable iron to overcome the hepcidin block?
So I'm going to talk to this next time. It's not
Okay.
relevant really to the diagnosis, but one statement.
Yeah.
In 1971, when I was MBBS student, the pharmacology book read, parenteral iron therapy should be given only if there is a reason to do that. All patients should be treated by oral iron. And then a student has to mug up 1, 2, 3, 4, 5, 6. Why you go for the parenteral iron therapy? Now, I'll tell you in the next lecture. I think the pendulum is totally turned. I say all iron deficient people should be treated with one single intravenous dose of total FCM therapy. Why? I will explain you next time. Because the problem of oral iron therapy are plenty. But if I do all that today, I will be left with nothing.
Understand. And I could appreciate also, I was a pharmacology teacher in medical college a few years back. So we used to keep asking these questions to the students in the Viva. So I perfectly agree to you, sir. Last question, sir. We also now appreciating the difference between iron deficiency and iron deficiency anemia. So no longer they are same, and iron deficiency has to be treated as well and also identified as early, because you also mentioned as early as possible, and we need to treat the iron deficiency. But sir, just I want to, because many times iron deficiency is noted when the patient gets symptoms, maybe for heart failure or maybe something like that, and then only we diagnose. But how early we can diagnose this iron deficiency, sir, or we need to again go through all these investigations to diagnose the iron deficiency?
I always believe that investigations are cheaper than the treatment.
Okay.
And the wrong treatment is dangerous. So I firmly believe that if a man or a woman walks into a clinic and says she's tired, and she wasn't tired yesterday, first you have to trust her. She has come to you all the way. That means she felt like coming to you. And then she says that she's got a symptom which she didn't have yesterday. And if you don't find any explanation for her fatigue, her tiredness, her work performance going down, and so on, I think ferritin is a must. And treating even iron deficiency is costlier than doing ferritin assay. So you have to believe Again, going back to my student days, we used to say CT scan of the brain, there should be an indication. Today you do it for all headaches, isn't it? So it's a mind block that ferritin is an expensive test. Ferritin is not an expensive test when you're diagnosing an entity. So you can't diagnose iron deficiency as the cause of fatigue or my nocturnal cramps in the legs unless I do ferritin. And imagine I want to give intravenous iron, FCM, which cost about probably 5 to 10 times more than the ferritin assay. And if I'm giving it to the one wrong person, not only I wasted that money, but I might have done some harm. So please do ferritin for the symptoms that I told you: fatigue, restless leg syndrome. When the person tells you that he's getting angry for no reason, he's getting mood swing for no reason, his cognition power has reduced, his concentration power has reduced, he has come to you that I've got this, and he didn't have this yesterday. It's your duty to do ferritin. Simple.
Thank you very much, sir. I think we have elaborately covered the 360 degrees overview of anemia in the all aspects, and some of the concepts were very, very new and very nascent, like IRIDA, which I found very interesting, and also a basic right from the signs and symptoms and pallors and all these things. So we'll stop here, sir, today, and we will catch up on 22nd on same time at 7:30, where we will discuss a next topic and we will understand more from you. So our second topic would be the evidence-based management of anemia during pregnancy, focus on ferric carboxymaltose, and that would be on 22nd and at 7:30 p.m. Till then, sir, we'll stop for a moment and join again after a week. Thank you very much, sir. I also thank 1,559 delegates across the country who are watching this webinar. Thank you so much.
Bye-bye and good night.
Good night.